Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. Well, today I have the pleasure of talking to my good friend Max Draper, who is lead clinician, as you can see, at Alphagenix. And so we're going to talk a little bit today about fertility and HCG and some of the things that are important to men on TRT. So thanks for coming on, Max.
Thank you very much for having me. I'm a big fan of the channel. Have been for a long time, so
Thanks.
it's a pleasure to be on.
Yeah, absolutely. No, I really appreciate it. Why don't we just start out with your background a little bit? You're a physician, and you're obviously involved in men's health and testosterone replacement therapy, but you didn't start out in that field. So what's your background? How did you end up in the TRT space?
Yeah, so I was originally a GP, classically trained, went through med school, went into GP training, and that was over about 10 years ago. And then through my own ill health, really suffered from low testosterone following testicular cancer.
Mm,
And, I suppose during that journey, being, I would say, fairly delayed in diagnosis and treatment, it really highlighted to me, A, how important testosterone is, and B, maybe we could do a better job at recognizing it and, getting people on appropriate treatment protocols, really. So it's kind of my own journey that inspired me to eventually leave general practice and
mhm.
dive into this full time.
Yeah, yeah. So how old were you when you were diagnosed with testicular cancer?
I was 29.
Yeah, yeah.
Fortunately, I didn't need any chemotherapy or anything. I just had my left. I always think when I say which side it was.
Left or right?
Yeah, yeah.
Yeah,
Left testicle removed.
yeah.
And I would say in hindsight, now that I kind of know how low testosterone presents,
Hmm.
it was probably 6 months, a year after surgery that there was a little bit of something coming.
Hmm.
And then it just gradually got worse. And then actually I had viral meningitis about 2.5 years after
Interesting.
surgery. And that was like, after that, I was living in a really bad place. And I kind of lived with effectively low testosterone, severe
Hmm.
symptoms for about 2 or 3 years. So,
Interesting. Interesting.
yeah,
So maybe a little
yeah,
bit of primary, and then you threw in possibly some secondary. Yeah.
yeah, yeah. I mean, looking back, I had a few times I did have my total testosterone checked. And I think twice I had my LH and
Hmm.
FSH checked.
Hmm.
Now, prior to the meningitis, I did have more of a primary picture,
Yeah.
and it was treatable.
Yeah.
Even by guideline standards, it was treatable. But obviously, I knew nothing about it, even though I was a physician.
Right.
My wife's GP, she knew nothing about it,
Hmm.
and so didn't get treated. Was getting ill quite often. Viral meningitis was just one of those things that I just kept
Hmm.
getting sick. And after viral meningitis, yeah, I had more of a secondary picture. So it's quite
Interesting.
interesting. It wasn't
Interesting.
fun, but it was
No,
interesting.
no, no. But it says a lot in terms of the education that physicians get. I mean, you had been suffering with, I'm assuming, fairly classical symptoms for
Yeah,
quite some time, right? And
yeah,
neither you or your wife, it sounds like, picked up on that fact that, oh, maybe there's, especially even after losing a testicle, that this could be a testosterone issue.
yeah. Well, I always say during that sort of, was it 5 years from surgery to treatment, maybe?
Hmm.
So I saw about three GPs.
Hmm.
I'm a GP, my dad's a GP, my wife's a GP.
Hmm.
Um, I had my oncology nurse who deals with testicular cancer and follow up.
Hmm.
And I saw a psychiatrist privately just to see their advice, because a lot of my symptoms were, well, I almost had all of the symptoms that you can list, physical and mental, barring
Hmm.
full blown erectile dysfunction.
Right.
Even though my libido, I'd probably say, was okay, but
Hmm.
it was, anxiety, apathetic, poor sleep, aches and
Hmm.
pains. I even had hot flushes towards the end where, it was almost like, I had the whole cohort of symptoms,
Hmm.
and really it's kind of put down to, this is stress, this is mental health.
Yeah.
And
You
it
just
wasn't
need
until I
just
went,
need an SSRI, man. That's
Well, I did go on an SSRI briefly.
yeah,
Yeah, that was no fun. That didn't help the belly fat, I can tell you.
yeah, for sure.
Yeah.
So, I mean, it's ironic though that, you know, three, including yourself, three highly trained medical professionals didn't put two and two together. And so it's, you know, how can we expect the lay person, you know, the lay man out there? Although, ironically, I think these days with forums and better access to information, it's a lot of men are going and they're requesting their testosterone to be checked, even though their primary doctor may not have thought to check it or even want to check it.
Yeah.
I still hear stories. In fact, I have a friend of mine here locally who went to the VA, and the new internist, who is a young female, refused. He asked if can we, you know, he was getting annual labs. Said, can we throw a testosterone level in there? She flat out said, no, we're not checking that. Just refused.
Yeah.
So I still hear stories about that. So there's just a lot of resistance. And there's also, I mean, I learned in school, and you probably did too, that, oh, you know, you've got two testicles. You can get, you know, if you lose one, it's not a big deal, right? The other one will compensate. You hear that all the time. And I learned that even in the late 90s, that you can get by and be healthy for the rest of your life with a solitary testicle. And that's not always the case, it turns out.
Mm-hmm.
Yeah.
Yeah. I mean, the thing I always say is, as you know, the average physician out there, and it's not I don't think it's out of any malice. I think it's just a lack of education.
Absolutely.
But we're bad at identifying the issue at low testosterone symptoms. We're bad at identifying possible symptoms. We're bad at knowing what tests to order, and we're bad at interpreting the results.
Yeah.
So it's kind of like the triple whammy.
Yeah.
Right. I certainly experienced that. You know that, but. You know, that was why it was career changing for me, because I've left general practice fully now because I love the work. And you do feel like you're picking up, and I'm sure you feel the same, you're picking an area where men are being underserved. You know, it's kind of like, it's not that complicated, but, you know, it feels like we're doing something that's very niche.
Absolutely. You know? And, you know, in primary care and also in emergency medicine, where I spend most of my time now, there are fewer and fewer feel-good moments, you know, in terms of where you can really feel like you have helped a man or a woman, for that matter. And it's something that you can take home with you at night and feel good about what you did that day. There's very few moments like that. Even in the emergency room, people are kind of surprised when I say that. But in the emergency room, a lot of times it's just this revolving door, and I'm just putting a Band-Aid on things. And, you know, I'm just pulling somebody back from the brink just for a few weeks, and then they're going to run and jump off the cliff again in about 3 months. And so, you know, in the end of the day, it's not as rewarding. But TRT in the men's health space, I mean, you can radically change a man's trajectory in life just by identifying that condition, putting them on a proper protocol, and then doing all the other stuff that obviously is very important, the nutrition and the training, and getting them on track in that way. I mean, we're both examples of that. Not only did it change our lives, but it changed the entire course of our careers. Like I would not, I mean, my story is not that much different than yours. I didn't have testicular cancer, but I had bilateral cryptorchidism, or undescended testicles for the listeners. And it was not, I was born overseas, and it wasn't picked up on and surgically corrected till I was after age 3. So it was a problem.
Yeah.
And, you know, not just for fertility, but eventually for my testosterone levels. So, it made a huge difference in my life, and it is, I'm still in the emergency department because I'm a glutton for punishment, and I still like a little bit of critical care, but in terms of those feel good moments, they really come from the men's health side of my practice, and I'm sure you can relate to that. I mean, how many guys' lives have you changed?
Yeah, I mean, you even get, you know, obviously there's the mental benefits, and then you'll have someone talking 6 months into treatment and they've lost, you know, their body fat percentage. I had one guy who spoke to me. I think he'd been on treatment for less than a year, and his body fat percentage had gone from something like the mid-20s to 17% body fat.
Yeah.
You think that even in that short space of time is incredible. Got stronger, felt great. It's just, and that, that's one aspect to it, let alone, like you say, I think a big part of TRT is stress resilience.
Oh my gosh. Yeah, absolutely.
I think that's one of the life-changing aspects, is the fact
Hmm.
that that's why it changes careers. That's why it changes all of these things, because you
Hmm.
suddenly get that drive and ability to cope better.
Hmm.
That,
Yeah. Yeah. There's no question. Yeah. It makes hard work feel good. It, it is a mood stabilizer, I've found in some cases. It just allows you to deal with adversity. If anything, the whole roid rage thing is such a myth. If anything, I've seen it has a calming effect. And we know that
yeah,
that's through DHT and then, and all the metabolites that are, derivatives of both testosterone and estradiol. These have important cognitive effects as well. But yeah, quite the opposite. It doesn't make men more aggressive. If anything, it has a calming effect, but at the same time makes them more assertive. So, which can be misinterpreted. I've talked about that before. It can be misinterpreted by maybe friends and family as aggression, but it's really not. You're just sticking up for yourself, and now you've got this new drive and motivation to do all the things that you've wanted to do in life, and be not a passive participant in your life, but more active. So um,
yeah. I
that's
think
I've noticed that a lot.
a lot of what you hope to see and often do see is calm and confident, isn't it?
Yeah,
That's
absolutely.
a good way of putting it, and
Yeah.
that can be misconstrued as being overly assertive, but I think it's
Mhm.
just having confidence and drive,
Mhm.
really.
Yeah, absolutely. Absolutely. Well, one of the things we were going to talk about today is the fertility aspects of TRT, because that's something I always, you have to counsel men on that as a physician before you start somebody on TRT, and there are implications for fertility. So, do you have a standard speech that you give, or what do you tell? Because it's important, because so many of our guys now are younger and younger, with testosterone levels plummeting worldwide. It's not the 50-year-olds that we see as much, although there's still plenty of those guys for sure. But now we're seeing, the 35-year-old, the 34-year-old, which always makes me a little bit uncomfortable, because, I always think this guy's got another 60 years of life left. And do I want to commit him to 60 plus years of hypothalamic suppression with TRT? And then, is this somebody that may want to have children at some point? Even if they tell me at age 35 that no, I don't want children. I mean, I can't tell you how many guys used to come to me as a GP. They wanted vasectomies at age 30 because they had a couple kids. And no, I'm never having kids again. And then, the relationship falls apart. They get a new partner 3 or 4 years later who's younger, and now she wants kids. And now they have to go in for a reversal. So, like, these guys change their minds. So even if they tell me, no, absolutely not, I don't want kids, I always think, well, you don't want them now, but
Hmm.
your situation could change. So how do you approach that with your guys?
Well, I'd add to that as well that when you have low testosterone, the idea of having a further child can be quite daunting.
Oh yeah, yeah,
When you
yeah,
go on TRT, if you
yeah.
start feeling the benefits and start feeling more resilient and stronger,
Hmm.
you might start thinking, actually, is my family complete? So yeah, it is
Hmm.
something that you've if there's the potential of wanting children in the future, you've really got to kind of delve into that
Hmm.
prior to treatment. And the
Absolutely.
listeners will probably know, but obviously it's because, like Andrew just mentioned, we're shutting off the signals down from the anterior pituitary down to the
Hmm.
testicles. So how I describe it is, if you go on TRT purely testosterone, the chances are that you'll at least experience some decline in your
Yeah,
starting sperm count.
yeah.
You can't, guarantee, well, guarantee would be the wrong word, but
Hmm.
not everybody will experience
Hmm.
infertility on testosterone.
Right.
But we've got to know that out of the gate, that that's what we're kind of, you know, it's all about making an informed decision. So it's kind of
Hmm.
like, this is a possibility, or maybe even likely, that you're going to have at least a degree of sperm count decline.
Hmm.
I like to, obviously every case is different. And it depends on the type of, testosterone deficiency, or the cause perhaps as well. So if you have, primary versus secondary,
Right.
you know,
Yeah, that changes
primary may,
things.
yeah, yeah. But I like to get at the start, pre-treatment, a sperm count done. You know, a
I
sperm
agree. I agree.
now,
Yeah.
you know, because it's all well and good going on TRT, and then 2-3 years later you want to have a kid and you find out you have no sperm. But
Yeah.
prior to TRT, it may have been already not great.
And that's a real concern. I mean, again, we talked about testosterone levels dropping. Well, sperm counts are plummeting. I mean, there's really no debate that that's a real phenomenon at this point. So yeah, like if your baseline is 20 million, which is technically still normal, but really it's not. Even with HCG, which we're going to talk about, you may never see 20 million again. And then that's where you're going to run into trouble. So I'm just like you. I really, really encourage guys to get, and nobody wants to go give a sperm sample. I mean, we've talked about this offline, but my girlfriend and I, we did in vitro, and it seemed like every other time I went to the clinic, they wanted me to give a sample. I was like, how many times do I have to do this? And it's embarrassing, and it's always like the cute, like 20-year-old female receptionist who like hands you the cup and you're like, oh, okay, I'll be back.
Yeah.
And you just have to just like suck it up, and they don't care. They've seen 100,000 guys like me come through that door, but it's embarrassing. But that's a really valuable piece of information, because if your sperm count is 200 million to start with, now we've got wiggle room, right? Like, we've got something to work with. But if you're infertile or subfertile right out of the gate, that's a problem, and you might need to go directly to in vitro. Regardless of what therapies we use for you. So,
and it might, I mean, I don't know if there's research to suggest this, but if you have a really good count at the start, even if, let's say, you were just on testosterone, probably the indication is that you might respond better to things like HCG and things, because in theory you've got healthy sperm production to begin with. So I think it kind of does influence the practitioner's confidence as well, I would imagine. We've got a good count here. Even if it does decline a wee bit, there are measures that we can take to bring it back up.
Absolutely. Yeah, and there actually is some good data on it. It's really old, but with HCG. But I mentioned this to guys too. If we'll just, I don't know, we could say 100 million. We'll just use, we got a guy that comes in, he's got a baseline pre-TRT sperm count of 100 million. There is a misconception that HCG will maintain that while they're on TRT, and that's not necessarily the case. Now they will probably continue to produce, there will continue to be fertile, but it's not realistic for them to expect that sperm count's going to stay at 100 million. I don't think I've never seen it actually stay with just HCG. With FSH in the mix, which we'll talk about, that's a different story, but they may go to 50 million. They may go to 30 million, regardless of what type of HCG protocol. And we can talk about, there's every possible protocol imagined. They all seem to work to some extent. But so that probably, if you go from 100 million to 50 million, is that going to be a major impediment? Probably not. But if you're starting at 25 million and now, the best you can get is 12 million or 13 million, well, that is, statistically speaking, that's a problem. There's a pregnancy curve that you kind of fall off of, and it starts to decline, if I recall correctly, as you go lower than 40 million, and definitely 20 million. Then you start getting on the steep part of that curve, where fertility rates start to go down. So it's just important for guys to understand that HCG is not a guarantee by any means that you're not going to still have issues, and it does really depend on a lot of factors, including where you're starting and how healthy you are at baseline. If you're fat and inflamed and generally unhealthy individual, your sperm counts, even if your counts are good, I mean, your morphology may be poor, and that's going to be an issue too. It's really complicated. That's sometimes the longest conversations I have with young guys is the whole fertility thing.
Oh yeah, because you at the end of the day, they've, I don't like to scare men off it whatsoever, because at the end of the day, there are options that we can employ. Obviously, what I always say is, nothing's guaranteed in the world of fertility, but this is the science behind what we can do. So, yeah, those consultations do tend to last longer. And even sometimes I'll bring them back, as in we'll have the initial chat and then have a think, and then we'll, maybe get the sperm count done in the meantime, have another chat, because there's a lot to take in.
Yeah. You've got to go in with your eyes wide open. And the last thing I tell guys the last thing I ever want is a year or two from now for a patient to use the phrase, well, you never told me blank. I never want that to happen. So I just let it all out. And it sounds like honestly, I spend a lot of time trying to talk guys out of testosterone because I really want them to know, like, what are these worst case scenarios that you could encounter, even though they may not. I just feel like somebody needs to tell them that. And I know for a fact that a lot of these, I call them windmill TRT clinics, they just if they even mention any of that stuff, they just gloss over it. And it's important. I mean, that's part of informed consent is you got to talk about worst case scenarios and what could happen and et cetera.
Yeah. Well, I think in the States, I think it's slightly different to the UK in the sense that you almost have a problem with over access to easy TRT.
Yes.
Over here, it tends to be, they're quite far down the line, sadly, sometimes by the time they get to realizing it is testosterone. Whereas I think for you have kind of the opposite end of it where they think, I've heard of testosterone, I'm going to get on this because it's going to, make me feel amazing. And like they need to know all the ins and outs of it, basically.
Yeah, we have a quality issue, I think, here, not a quantity issue so much.
Yeah.
Although who knows, that might change in the future. So, so tell me, let's talk about your HCG experience, because you and I both, I started on HCG very early in my protocol. Did you start on HCG right out of the gate with testosterone, or how did the HCG, when did that become part of your protocol? And tell me about your experience with it, because it's a good example that every man is different, right?
Yeah. Well, I was actually originally on the branded gels through the NHS.
Okay.
Yeah, and because my levels were pretty rubbish, they actually did make a wee bit of a difference.
Yeah. How low were you, by the way? Just out of curiosity, did you recall?
I can't exactly remember. Below 7 nanomoles per liter, which is kind of.
So that's less than 300, I think.
Now. Oh yeah, a lot less. I think. Yeah. 200 maybe, something like that.
Yeah, that's pretty low.
Yeah, and I can't remember the exact number, but it was pretty low. But I was on the gels, and then obviously, that's where I actually started speaking to Alphagenix, was wanting to go on cypionate plus or minus HCG. When and in hindsight, if I could go back in time, I would have just switched over to cypionate to begin with, and then maybe dialed that in, and then added HCG in. Because what I kind of did off starting was HCG with cypionate, even though I had no immediate sort of children plans at that point. And HCG was a fun experience for me. It was kind of like, you're describing roid rage there.
Yeah.
The misconception. It was almost like that. I just became an unpleasant person.
You had HCG rage.
Yeah, it was just.
That's really interesting. Right? Yeah. You were angry pregnant woman.
Yeah, basically. But looking back at HCG, I was irritable. I was kind of just almost like paranoid.
Interesting.
And physically, I just didn't feel on top of my game. I even noticed in the gym and things, I would lose about 10 to 15%. And I can't, you talk about the biology and the science of HCG. I can't quite explain all aspects of why it made me feel like it did, but just different people respond to it. I think part of the problem with HCG is people are kind of described it as, well, it's basically LH with a longer half-life, and it's like,
it's not.
No. It's not LH with a. Fortunately, it works on the receptor, but it's not the same thing. And that's what I always tell people, particularly if they are running into issues with it. So I started on a fairly decent dose, stopped it for a while. Then we started, thinking about having kids again. So I ended up trying to get away with a low sort of daily dose of it.
Yeah.
And
Yeah. So you
yeah,
did daily microdosing?
yeah,
Yeah.
yeah. Tried
Uh-huh.
that out.
Mhm.
Added some FSH. So that's my preference if guys can afford it, is to kind of run a level of HCG, that gives you that intratesticular testosterone
Mhm.
and
Mhm.
estrogen, and then add in the FSH, because that really completes the cycle.
It does.
Yeah, but it's just FSH is much more expensive than HCG
Yeah.
over here.
Yeah,
Yeah.
and it is here too. We were again talking about that offline, and
Mhm.
with in the United States, just like HCG, we used to be able to compound it here, and obviously compounded drugs are far less expensive. And
Mm.
for reasons I don't want to get into, we can no longer have compounded HCG and recombinant
Mm.
FSH, and the prices have 5 to 10x, unfortunately, on that. So yeah, recombinant FSH, which many times is the crucial missing piece of the puzzle for some men. Yeah, it's just ridiculously expensive. But as we talked about, I always joke, like, if you can't afford recombinant FSH, I don't you probably can't afford a child for 18 years. I mean, my son is 13 months now, and I can't, and we're pretty frugal, but that little guy's expensive. So,
Oh,
yeah.
I get told off. I'm the opposite. I'm the money spender in this house when it
Yeah.
comes to the children and things. We go out and I'm like, get back, and my son's got a new toy, and my wife's
Mhm.
like, you bought him another toy, and I'm like, yeah, but
Maybe.
yeah, yeah,
But but he wanted it.
yeah, yeah,
Yeah, you have to resist. You have to resist that.
yeah.
But yeah, it is frustrating. Did you? I don't know if you want to get into this or not, but Did they make you do a semen analysis before your surgery? Was that
Yeah,
part of? I would assume that would be part of your pre-op
yeah,
workup,
yeah.
and then did you ever have one post with HCG plus minus FSH?
Yeah. So pre-surgery, I had a sperm count, and it was frozen.
Mm-hmm.
Um, then, oh god, it would have been a long time after the surgery when I went on HCG and FSH.
Mm-hmm.
I had a sample done, but I can't remember if I was on anything. I think it was just on testosterone. It was 5 million.
Yeah.
Um,
Okay.
so
Okay.
not great, but
Yeah, but still 5 million sperm on testosterone. So
yeah,
it's a great reminder. Like it's not
yeah,
birth control. It is
yeah.
not birth control. So even though your
One
odds would have been
testicle,
low, what's that?
one testicle, and
Yeah, working overtime.
yeah,
Yeah.
yeah,
Yeah.
exactly.
So well, yeah. So that's in my particular case, I had a count of, this is going back a long time because I've been on testosterone for over 10 years, but pre TRT with bilateral cryptorchidism, I think my baseline sperm count was like 7.5 million. So not good. Total testosterone was hovering right around 300, and this was in my mid 30s. And then actually, so it's interesting. I got on a high dose HCG protocol around the time when we were trying to conceive. And by high dose, I wasn't microdosing like you were. I was doing approximately 2,000 IUs every third day, which was
Mhm.
a protocol that I found in an andrology um, journal article, from about 2015. And that's one thing I'll say, that there's very very little data out there that I'm aware of, and unless you've seen something that shows us like what is the best way to dose HCG for fertility. I mean, you'll see
No,
protocols like I've seen 5,000 IUs twice a week in some of the andrology things. I've seen 3,000, 2,000, 1,500, the 250 to 500 every other day. They all seem to be effective to some extent or another. So we'd
yeah,
have to have like some big giant randomized trial, which I would love to see one day, to figure out what is the best one. But generally, higher doses for fertility, because my understanding is that you can obviously raise the intratesticular testosterone pretty well at doses above 250 to 500, but then to get some of that FSH activity, because it's not quite as specific for FSH. And correct me if you have come across something different, but that tends to require higher doses of HCG. So I went on a high dose protocol, and my counts actually went to like 12.5 million. So even though I had these like damaged atrophied testicles, they still, it was, I was able to beat the dead horse and get a little bit of life out of them. So I probably had, I had baseline high LH and FSH. So I was mainly a primary type picture, but clearly I probably had a bit of secondary as well, because there was still a little bit of life there that I could squeeze out of the boys with some HCG. But then when I went on recombinant FSH, which I went on the very high dose of it, because the price hadn't gone up. I did the 150 IUs Monday, Wednesday, Friday. I got my counts up over 20 million, which technically is in the normal range. And it was only at that point, and we had actually had 3 natural conceptions at that point, which is the first time I'd ever been able to get anyone pregnant. And unfortunately, we had miscarriages with those, and ultimately went to in vitro, not just for my issues, but she had some female factor stuff as well. So and ultimately that ended up working out. But it basically from 7.5 at baseline up to over 20 million for me with high doses of HCG and recombinant FSH. And the interesting thing is I stayed on testosterone, because that's another thing we should probably talk about, because almost every andrology protocol that I've seen, as you go through the flow chart, the very first thing is stop testosterone. What are your thoughts on that?
Yeah, it bugs me, this one. I mean, I was actually we have 2 children, and when I was on TRT, I sort of actually ended up speaking to a fertility doc, because we had sort of multiple carriages at different times. And I said to them, I'm looking at this regarding the options, and he said, well, I can refer you to an endocrinologist, but you'd have to stop your testosterone. I kind of said, but why?
Yeah. That's what I said. Why?
Yeah. I mean, when we're putting in HCG and FSH, we're essentially stimulating the receptor that, so where are we stopping? Why are we stopping the testosterone? It doesn't quite make sense. In fact, it makes no sense, because we know what we're missing when we're on testosterone alone, and we have options to replace exactly what we're missing. And at the end of the day, that stops the guy hopefully feeling rubbish. If they tolerate HCG, then FSH, unless you're allergic to an ingredient in the recombinant FSH, you're going to not really feel it, because it's not really very hormonally active, and it's pretty bioidentical. HCG is the one that can, cause issues, because some guys don't get on with it. But yeah, I don't see, I always say to a guy when I'm counseling them about, even prior to TRT, it's like, these are the options for when we come to it. What are we going to do about the fertility side of it? HCG, adding an FSH, all of that. And I say to them, like, the last thing we would want to do is, though, take you off your testosterone. That's not anywhere near my first rung in the whole treatment protocol.
And that's the last thing they want to do as well. I mean, just like especially guys who've been on for a while, and they've reaped all of these benefits. They feel so good, and they're like, oh shit, I have to go back to feeling like I did before, potentially. It's sort of a psychological barrier for them, and I don't blame them.
Yeah, 100%. And I just don't see how you can explain it biologically being necessary when we've got the replacement for what we're lacking.
Yeah. And there's so many, I tell guys this, there are so many variables, and again, so much individual difference, that we might need to stop your testosterone. But if you're up for it and you can afford the recombinant FSH, that would be the preferable route. Let's keep you on your 120 milligrams of testosterone weekly, whatever your dose is. And then let's add in let's give you back LH and FSH. And let's do all these other things with, antioxidants if we need to, and improving your overall nutrition and health.
I always aim not to have to stop testosterone, is basically my kind
Yeah.
of gauge of it.
Yeah.
You know, I think that's a good place to kind of start out, because at the end of the day, that's the bit that's making you feel better. You know, some people find HCG actually does make them feel benefits, but
Mm-hmm.
most people, you know, just don't have any side effects from it. But then there's that cohort of patients who don't like it.
Yeah. Yeah. And you were, it, yeah, it definitely affected you obviously pretty severely. I was in that middle group of where it's sort of neutral.
Yeah.
And I've come off of HCG now. I've been off of HCG since shortly after my son was born. So coming up on about a year. And to be perfectly honest, I don't feel any different.
Yeah.
I feel no different. And I had been on HCG for 8+ years prior to that, at least. So I'm in that middle group where it's neither positive or negative. I needed it for fertility. I didn't really care about the atrophy because I already had it, at baseline. So it just wasn't an issue. But then now we should maybe talk about, there's this other group of men that really do feel good on HCG. And I've got a handful of patients that even just for libido purposes, they just love it. They just absolutely love it. And some of them are men in their 40s and 50s.
Mm-hmm.
And they have no fertility desire. They don't care if their testicles atrophy. They like the sexual parts of it. It does seem to help. There's a subset of men that sort of get desensitized with testosterone in terms of like penile sensitivity, orgasm, volume of ejaculate, and that's a problem for them. And there's a subset of men that HCG helps with that. There are a whole bunch that it doesn't make any difference at all. So,
Yeah.
and I've always wondered, there's a lot of potential mechanisms for why that is. So, not just testosterone and estradiol elevations, but, perhaps, backfilling with DHEA and pregnenolone, and that's a highly variable thing, and all
That's
over
a
the map. Highly
that's a
variable, yeah.
debated topic as
It
well.
totally is, yeah. And, guys that want to learn more about that, I refer you to Dave Lee's videos and his website, because he has sort of made himself kind of a local expert in that field. But what he says about it is spot on. Is highly variable. You should get blood tests to see if that's an issue for a guy or not. But it gets complicated, and I think we have to be humble as physicians and realize like we don't know everything, and I don't have the power to predict how a man's going to do on HCG. I've seen guys do extraordinarily well, and then I've had a handful of guys like yourself that are just like, get me off this stuff. I had one guy a number of years ago that he developed just the most horrendous cystic acne I've ever seen on HCG, and he was not a terribly acne prone guy, but it was just like it was going to be cosmetically scarring, so we just had to like get that out of his system. So it's hard to predict. It really is hard to predict.
Yeah, 100%. I think people just need to be aware of the fact that if they go on it, and just to be wary of the fact that it's not bioidentical LH, so that if you do get issues with it, it's a potential trigger for those issues. I think it's really interesting to try and work out, why is it, and I don't have the answers. Why is it that some guys find those benefits from it? Penile sensitivity. Obviously, the ejaculation is probably more easy to explain that they've got some testicular stimulation going on. The sensitivity one, is that anything to do with local testosterone being made as well? That's another thing I've wondered. But we don't have all the answers with regard to HCG, but it is and I think it highlights again, as with every sort of scenario in TRT, it's very individual.
Yes, very much so.
It makes our job interesting, because otherwise it'd be pretty boring if everyone did exactly the same thing. Yeah. If everyone needed the same dose and they needed the same regime, it'd be kind of like, same, here you go. It keeps it interesting as well.
It does. Yeah, it absolutely does. And have you run across guys where HCG has worked for them initially and then has just sort of stopped working? You hear about the idea of that you're developing antibodies or developing some other, resistance to HCG and having to increase the dose. Have you run into that? I can't say that I have, honestly.
No, not regarding
Hmm.
atrophy. I haven't
Yeah.
noticed that, because
Hmm.
what I say to guys is, if your receptors were going to down-regulate because
Hmm.
of HCG, well, you presumably know, because your balls would start shrinking. So that would be, one would suspect that would be an indication.
Hmm.
Um, I have had guys who have initially felt that boost that we mentioned there when they start HCG, and then it tends to kind of wane over the
Hmm.
months. But whether that's maybe a honeymoon period kind of thing,
Hmm.
like very similar to when you start testosterone, some guys get that
Yeah.
real big sort
Yeah.
of almost like dopaminergic thing. Um,
I've seen the
but
same thing.
regarding desensitization at the receptor level and things, or the I've not really come across it,
I
but
haven't either. And I stayed on the same dose, which was again it was approximately 1,500 IU's every third day for 8+ years. And um, and again, I was in that middle group that didn't feel really poorly or didn't feel fabulous. So maybe I'm not the best example of it, but it doesn't seem like it's. I mean, it's one of these hypotheticals that I think we just have to be aware of. And it would make sense that the answer to that would be to increase the dose. If there's antibodies which are produced, which there is documentation that can occur, then the answer to that, you're not going to get rid of the antibodies, so you just have to sort of overwhelm them and up the dose
yeah,
and
yeah.
up the dose.
I've heard in the bodybuilding world,
Um,
people say about how very high doses of HCG seem to, you seem to get LH receptor desensitization, down regulation, and things like that. But I've not come across that as something actually in practice.
yeah, I
And
haven't either. I haven't either.
you were on. I mean, 1,500 every 3 days is not a huge dose, but it's a
No,
fairly. It's not a sort of 500 twice a week.
right. And it was
But you,
sustained for years, many, many, many,
yeah,
many years. So, it would be, you'd think that that would be, if anyone was going to have antibodies, it would be me. Um, and I'm not aware of any like commercially available tests to see if I have antibodies, and I don't really care. Um, but anyway, it's sort of one of those hypotheticals. So,
yeah,
you
yeah.
know,
At the end of the day, a lot like we were saying before, how much is there on testosterone with HCG
hmm
research wise? A lot of this we're kind of working with theory, science,
very
and
much. Yeah.
research we have.
Yeah. Yeah. And again, so many of the studies are with much higher doses than
Yeah.
we see in clinical practice. I,
Mm-hmm.
I'm not aware of any, and I could be wrong because I don't read everything, but like daily microdosing, I've not seen any papers on that. I've seen every other day dosing, and I obviously could be wrong, but we know that daily microdosing is effective.
Yeah.
Um, it is,
Yeah.
it's just so this is again one of those areas in TRT that we have, years and years of clinical evidence to support a practice, but if you try to find, a paper to support it, you might struggle a little bit with that. So there's just not a lot of money in HCG research, I guess. Big pharma's not interested.
Yeah. Basically, yeah.
Yeah,
It's it,
yeah,
it's sad, but it's true. Even though, God, how many men must be now on testosterone and HCG combined?
yeah,
There must be, tons of guys out there. But
yeah.
yeah,
Well, there's going to be more. I mean, that's the thing. This global decline in testosterone levels is not. It's global, and it's only getting every decade that we study this, it just gets worse and worse and worse.
Mhm.
And now we have men in their late 20s who have the same testosterone levels as men in their 60s did 30 years ago,
Yeah,
which is just
yeah,
mind-boggling to me, and that the implications to society and just like human civilization of having, you know 4 billion hypogonadal men running around the world doing nothing,
yeah.
is kind of frightening,
Just lower the reference range.
well,
That's
that's,
it.
yeah, then it's all better, right?
Yeah,
Yeah,
yeah, yeah.
yeah,
That I always have to speak to guys about that. Yeah, it does my head in. I mean, it's not the lab's fault, but is no one going to intervene on the fact that the lab ranges are just going down and down and down, and we're kind of just like,
no.
the new normal.
Well, I mean, how much sense does it make to sample a chronically unhealthy population and then use that as your reference range? Yeah. I
Yeah.
mean, we should not be using overweight men, which is what they used in, at least in the States here, for some of the more recent reference ranges. They said, well, they were healthy men who were non-obese, but they still were overweight by BMI. And we know, obviously, BMI does not, it's not the same as a body fat percentage, which is a much better measure. And so, how many of those men were actually obese by body fat percentage, which really is only 25%. 25%, above 25% body fat is considered clinically obese. Well,
Yeah.
you could easily have a BMI of 28 and be obese, and then be included in that sample.
Yeah.
So
Yeah. I mean, in an ideal, what we would do is maybe go back 30 years, get a bunch of fit men at each age range, and then create a new, maybe 30, 40 years, just thinking about the endocrine disrupting chemicals as well. And then we would kind of get an idea about what is actually physiologically a good reference range for testosterone.
Right.
I wouldn't be surprised, in American numbers, if it was significantly above where you guys have the reference range now.
Oh, it would be. I mean, almost certainly it would be. I mean, I think if you took a group of healthy 18 to 40-year-old men with, body fats between 10 to 15%, you isolated them somewhere and like detox them from all phthalates and parabens, and like put them through some sort of machine that like filtered all that crap out of their system, and had them eating a healthy diet, and then check their levels. And that should be the reference range. Like, what is a normal ultra fit healthy man? And I bet you would see 900s, 800s probably. And there are still guys like that running around. I've got a friend that I train jiu-jitsu with, who's in his late 30s, and he just went and got his T levels checked, and he had a total testosterone of close to 900. Yeah, and he's not on anything at all. So yeah. And he still drinks too much beer, so it'd probably be higher if he was a little healthier. But there are guys still out there like that, but they're rare.
I had a chap whose natural levels were 43 in our unit, which you times it by roughly 30 with your guys. So that's I think that's well over 1,000.
Oh yeah, 1,200-ish. Yeah,
mid to late 30s, pretty active, but not some sort of huge, testosterone. You didn't look at him and think, oh my god, this guy's the tip top shape in the world. And he just 43. So I think our reference ranges are, sadly not quite where they should be.
Well, he's by today's he's super physiologic by today's. So you should do something to bring that down. It's not. That's dangerous, right?
Yeah.
You better bring that level down, Max. That's not healthy.
Exactly.
Well, one of the things I thought we'd maybe close up on, with the fertility thing is, talking about enclomiphene or clomiphene, because that gets thrown into some fertility protocols as well. Do you ever use either one of those, or have you had any guys who have done well with either one of those? I found it to be variable, as just like HCG.
Yeah, my personal opinion of it is, if you get a young guy who is kind of in fairly short term going to be having, trying for a baby, then maybe that one of the SERMs makes a bit of sense. My issue with them is I just don't think that guys feel as good as they do with testosterone, and that probably is because of that estrogen receptor, not being blocked in the brain, and the mood and everything like that. I just find that particularly the mood doesn't pick up with them.
Correct. Yeah.
Where I see it coming from. Some guys feel physically a bit better with them, but mentally, I just keep coming across this idea that, it doesn't make them feel as good. And the other thing is, I'm a bit of a stickler for this idea that there's not any long-term use of Clomid in men as well as there. Do you know what I mean? So, we don't know, if I stick you on Clomid or on clomiphene, then in a year's time, we're kind of heading into a bit of an unknown territory.
There's very few studies on clomiphene. And there's a couple that go out to 5 years, but it's I have never. I'm in the same boat or same camp as you are, that it for shorter term use in select individuals, that, yeah, it might have some utility. And in the fertility space, that is, that's kind of the one of the guy. If somebody has symptomatic low T and they're actively trying to conceive, I don't want to start them on testosterone. I want to talk them out of testosterone, even with HCG and recombinant FSH. But if they feel terrible and they're symptomatic, maybe there's a use case there for N-clomiphene. Do you guys have N-clomiphene? Do you have access to that over there, or is it just clomiphene?
Just
Okay.
clomid, which is
Yeah.
a shame because of the zooclomiphene. I think is part of the issue with it.
It is the issue, yeah.
Yeah.
Yeah. Yeah, we can get it here through compounding pharmacies, and so I use it occasionally. I don't prescribe I haven't prescribed clomiphene in quite some time because of all the issues you just mentioned. But I do notice anecdotally that men seem to do a lot better on N-clomiphene,
Yeah.
and if you pick it's all about picking the right patient for the right protocol for the right patient. So there's a subset of guys that can do pretty well on it for a year, but then after that, like you said, I don't think it's a good long-term option. Even though the studies say it's safe for that long period of time, I just am like generally opposed to blocking hormones in general for long periods of time, unless you have a very specific indication, like a hormone sensitive cancer or something.
I was going to say actually the same thing. There's two things I don't like doing is blocking hormone creation and blocking receptors for them. I just don't think it's a long term. It's a long term.
There's too many unknowns, and there's a lot of knowns that are known harms. And we can go off on aromatase inhibitors maybe another time, because I think we both feel strongly about avoiding those if at all possible. But yeah, I think and clomiphene for a young, like the classic patient for me, it would be the young obese man who is actively seeking fertility and wanting to have a child within the next year.
Yeah.
It's not unreasonable to have that discussion in combination with aggressive lifestyle modification, because sometimes it gives them just enough of a boost to get them off the couch, and then once they're done with having their family, and maybe if they've made the lifestyle and body composition changes, we can just reassess at that point, because at least it keeps the axis going.
Yeah.
That is the one advantage, is we don't have to do this HPTA reset, which is a whole nother ball of wax, which is not always successful. So I'd rather not suppress their gonadotropins if I can help it. But it's for just regular TRT or just for treating hypogonadism long term. Yeah, I'm not. I think we're on the same page there. Not a fan.
I'd like to have N-clomiphene as an option, because
I think it is. If you're going to use a SERM, I mean, I think that's the one to use, because the zooclomiphene with that, it's got a ridiculously long half-life, and it does accumulate to ridiculously high levels over months and months. Not a huge fan.
The other thing that I often mention to guys as well who have been taking Clomid is that I think over time, because it's sort of like a estrogen isomer mix or whatever, your SHBG does tend to climb.
Yeah.
So you do end up binding up more of your free testosterone. So that's another reason behind if you're going to use it, it's probably not a long-term solution, really.
Right. Yeah, I think for short-term use, and by short-term, I think less than a year is what I generally. I don't think I have anybody currently on it that's been past a year. But I have a couple guys right now on it that they feel great. On N-clomiphene, they're very happy with it. So I just warn them. I don't know how long the good times are going to keep going. Everything comes to an end at some point. So at that point you can reevaluate, I guess, what you want to do. So,
and that's because they're feeling better, and you always have to be like, this might not last forever. But it's quite a hard conversation to try and explain, isn't it? It's just like, I've got my doctor's hat on now, and I'm just saying that it's working right now, but we know that these don't always work for that long.
Yeah, just be aware. Yeah. Well, that brings us to the final thing maybe we could talk about. I actually did a consult years ago with a guy from the UK who, it was actually very similar. He had testicular cancer in one testicle and was very hypogonadal. And the NHS endocrinologist there originally put him on clomiphene, which failed miserably, of course, but then put him on HCG monotherapy, and that was not terribly effective either. Do you see much of that over there? Because I still run into that every now and then over
Yeah,
here. HCG monotherapy.
I just had a transfer of a chat the other day actually, and I couldn't quite work out why they were doing the HCG monotherapy, but it wasn't even, it was 500 3 times a week, 500 IUs 3 times a week, which to me, I think sometimes mistakenly, maybe people think of it like as boosting the system rather than, actually putting something in which is a new version of the system, if you see what I mean.
Right.
So I'm not a huge fan of monotherapy, like we were saying before, because at the end of the day, we're trying to make men feel healthier, better in themselves, and what do they lack? Well, it's testosterone. So I'm fairly simplistic in my thinking. Here's the replacement of what you're lacking. Like we said before, maybe fertility. If you have to come off testosterone, you would maybe ramp up a decent dose of HCG. But as a monotherapy, I just don't think that you're going to get the best symptom resolution. And also, obviously, it depends on what's the state of the balls like before treatment.
Precisely. Right.
It's all things.
Yeah. If there's any component of primary, then it's going to be an issue. Yeah, I have never seen it successful long term. Again, greater than a year. I've had one or two guys that I've used it on for specific medical indications that did okay in the short run. But yeah, it's just not a viable strategy. But you still see it, and you even see it from the endocrinologists. Because on paper, it's exactly what you need, and things like that. But outside of like Kalman syndrome and some of these like rare genetic developmental issues, I just don't think that there's a place for it either, unfortunately. And it's just like it's sort of like enclomiphene, but it has the added downside of suppressing your axis. So and the other thing too, I mean, you may not get to the level that you need to be optimally healthy. You certainly won't get super physiologic generally on HCG. It's very rare for that to happen. But some men do, there is a subset of men that do need to be slightly super physiologic, and you're just not going to get there. And especially in older men over the age of 40, like, and certainly over the age of 50, just the end organ just doesn't respond like it used to. And so, so we're on the same page there too. I just am not a huge fan.
To hammer home that point, because I don't think people realize this, is that HCG suppresses your own.
Guys don't realize that. I found that a lot, especially in the steroid world. They use it as part of their post-cycle therapy, and I'm like, no, if you post-cycle therapy, I guess what I think of it as is restarting your hypothalamic pituitary axis. And the first two parts of that, the H and the P, are the hypothalamus and the pituitary. It doesn't do anything other than suppress those. So what are you doing? It doesn't do that. And I like the idea of producing my own natural testosterone. Well, okay. I mean, but that's just an idea. I mean, testosterone is testosterone.
Mm-hmm.
It's funny. Like, I mean, really all roads do lead to testosterone, right? Ultimately, like, we can fiddle fart around with all these, SERMs and HCGs and with younger guys, but ultimately, where do almost all men end up eventually on, bioidentical testosterone replacement, because that is what works. I mean, it's predictable, it's highly effective, it's well understood. All these others have all these just variables that are just so difficult to manage sometimes, but at least, I don't know, I just feel like good old testosterone cypionate or enanthate is like, it's the old standby. Like, I know that I can count on that at some point. So seems like we all end up there anyway.
Yeah, I love the creams as well. I
Oh,
love
true. Yeah.
creams. Yeah.
Yeah. Yeah.
So,
I personally, have you used the creams? I've never used the cream, but I have patients that love them, that love the
yeah,
20% compounded cream.
yeah. I'm actually doing a bit of a self-experiment,
Oh, are
not
you?
fun,
Yeah.
right?
Yeah.
But I'm doing like I've lowered my injection dose and just adding a bit of daily cream
Yeah. Okay. Yeah.
just to see how I feel. I may end up changing over.
Yeah.
Um, I think there is potential benefits
Hmm.
to the cream route. Um, I think what I quite like doing is trying things that I'm going to be recommending to people as well. So
Sure.
and there's no
Yeah, I
don't
agree. I agree. If
yeah
as long as you're not, doing anything dangerous, I guess,
yeah
which you wouldn't do.
yeah
You wouldn't recommend anything dangerous, but
yeah
yeah, I think about it every now and then. I was like, oh, should I just experiment with the cream and see? But I feel so damn good on my
yeah 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 yeah.
testosterone injections. I sort of don't want to mess with it. But anyway, I those in my opinion are the two by far the two best delivery methods. Everything else is way down on the list. Although there's there are guys that like their pellets and have they like their Nebido
Mhm.
and whatnot, and that's okay. I talk to them when I have a new patient. I lay out all the options for them, even if it's something I don't provide, because I just want them to be educated about that and let them decide. And they can always switch. You
Yeah
know,
yeah.
if the
I
pellets aren't
think
working, you can always switch over later.
yeah.
Libido or
I think
whatever.
I think if you say for most guys, the gold standard is either a fairly frequent injection of
Mhm.
stipionate or enanthate,
Mhm.
and then or the compounded cream. Those seem to be, in terms of symptom resolution, get
Yeah,
good
by
consistent
far,
level.
by
Yeah,
far. Yeah.
and it's funny because it tends to be, and I've seen other people say this. The cream tends to be more maybe because of the DHT, you
Mhm.
know theoretical more conversion
Mhm.
across in mentally maybe the cream and physically more the injection, but everyone's different.
Yeah,
Yeah.
yeah, absolutely. Yeah, well, there's yeah, when we both know people that are huge advocates of the top goal and
Mhm.
have done extremely well on it, and they're very knowledgeable, and I respect their opinion on it. So
Mhm.
yeah, I if a patient really asks me my opinion, I will steer them to one of the two. And there's pros and cons. Some
Yeah.
people don't like to have to do anything daily or twice a day, which is probably what most people do on the cream. Some people
Mhm.
have horrible needle phobias and they just can't get over it. So,
Yeah.
but yeah, those are I agree, yeah, by far the best. So,
Mhm.
Max, how can people get a hold of you and Alphagenix?
Yeah. So
Let's give it a
Alphagen,
plug.
yeah, I've just it went out of my head then. Alphagenix.co.uk. We're on Instagram as well at Alphagenix and at MaxYourT as well as my
Mhm.
Instagram account. So if you go through the Alphagenix website, there's information about what we do. There's
Mhm.
the email for the team, telephone number, all of that stuff. Yeah,
Okay, awesome. Well, thanks for coming on, Max.
pleasure.
Yeah, if you guys have questions, get a hold of Max. You can leave them in the comments as well. I'll pass them on to him, and we're going to do some more of these in the future.
Yeah,
So
brilliant.
awesome. Thanks, Max.
Cheers.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer reviewed, research backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.